patient is hypoxic, yeah. So you're gonna run to the patient, the patient is not written here.
Oh, sorry.
Run to the patient
Okay.
bedside.
Okay.
He's hypoxic, make sure that he's actually hypoxic, right?
Yep, he's hypoxic.
And what are you gonna do first?
Sit the head of the bed up and get him some oxygen.
Fine, let's do that. The clock is ticking, tick tock, tick tock, tick tock.
Here we go,
tick.
here we go.
All right, and then he's still hypoxic.
He's still hypoxic.
Oh, she's looking for the oxygen. That's good.
Oxygen.
Thank God there is a nasal cannula in the room. The last one there wasn't. All right, so for the nasal cannula.
I want to see if there wasn't. I would have
Right,
gone and got
and
one
then
already.
what do you set the nasal cannula at, Courtney?
Go to 2 and keep going up. No, 10.
Take no prisoners.
Take no prisoners.
Yeah.
All right, we're just
Flush it.
Kill everybody. Just so let's. I want everybody to hear this, okay? So this is the sound of 15-liter nasal cannula, right? And that's the max that's written here, 15. Above that, if you really squint, you'll see something that says flood. Flood meaning 150 liters per minute. Listen to the sound. So this flow meter, every flow meter that we have can give 150 liters per minute. 150 liters per minute. Now 150, they don't write it because in order to do it, one of this is going to be all the way to the wall, to the ceiling, right? So they do it all the way to 15. After 15, they say you're on your own. We're not going to measure. Just go to 150 and whatever. 150. What is 150 will do? Will give you the Jesus effect. This will look like Jesus because it's going to go in the nose. It's going to fill the nose, the nasopharynx, the oropharynx, the mouth. It's going to come out of the mouth and make a halo of oxygen around the patient. Literally, the oxygen. If you have a Geiger counter and this is a radioactive oxygen, it will look like Jesus. And anywhere the patient is breathing is going to receive, even if he opens his mouth and he doesn't breathe from his nose, he's going to have 100% oxygen. So that's very important in the beginning. That I'm not going to do this because we're not going to hear anybody. But let's say we'll do it 150. So now he has apneic oxygen. Let's say the patient is not breathing at all. This is apneic oxygenation. Just the oxygen present in the trachea without even any movement. Nobody knows why. It's molecule pushing on molecule. Patient oxygenate. But he's not exchanging CO2. CO2 is going to rise, but at least he's going to survive, right? So we did that, right? And we put him on 150. And 2 other nurses arrived, right? And then we found that the patient is vomiting. What are you going to do?
suction his mouth out.
So we forgot something. Before he's suctioning the mouth, but 2 nurses are here. What are you going to tell them to do?
Call a rapid and get some help.
Well, there's no rapid in the ICU.
Well,
Rapid on the floor, yeah. So we'll call the provider, call one of the PAs, one of the residents, one of the interns, and or the attending, anybody who's there. Come on in quickly. Meanwhile, another nurse is suctioning the patient and turning his to the side and stuff like that. Okay. What's the other thing that you need to assess?
Mental status.
Mental status. Is he awake or not? Because if he's awake, we can talk to respiratory and say, let's say he's not vomiting, and we say, okay, we're gonna put him on BiPAP. Meanwhile, all these things going in your head. The attending probably gonna say, yeah, let's see, he's not vomiting, he's awake, he's hypoxic, let's call for BiPAP, or heated wire, high flow, or whatever, right? But let's say his mental status is not great, right? Mental status is not great, and Professor Drake arrived, right? So now both of you are by the bedside, and you decided that he's vomiting, right? We cleared the vomitus, so he's not vomiting anymore, and his mental status is not 100%. He responds when we say his name, but not 100%. He's hypoxic, and his saturation is like 90% or so. So what are you gonna do?
I would assess his airway and probably plans for intubation.
Plan for intubation, right? So BiPAP is off the window here. Mental status is horrible. We're having mild hypoxia, and he's tachypnic, and he is and he can't protect his airway. So what are we gonna do? We're gonna ask for. So what are you gonna do? You want to intubate. What are you gonna ask for?
The intubation box, sedation. If we want to do paralytic, ask for paralytic to get all that. The saline, neostick, get a vent so like call respiratory if they're not already here to get a vent ready.
Sure.
Call you.
Somebody get the airway box, please. Quick, yes, airway box.
Call the attending to come
and
also.
somebody gets the air, when she comes in, I'll send somebody else to get the airway card. Okay, just one second. But let's make it so real, okay? So let's get the airway box first.
And so while they're doing this, we would continue to suction, support the airways best as
So
possible.
people, everybody, we have to work in parallel, right? Now that nobody's like looking here. There's always a nurse assessing the patient and never leave the room, but there's always somebody helping you. So you don't ever leave the room to get something. You don't ever leave the room to get something if you're the only provider and you're the only nurse. Other nurses are helping to get some things from outside, right? So now we got the airway box.
Do you want to do MAC light or glide scope?
So, one second. So now, we're gonna do the MAC blade, right? Before you do the MAC blade, you're gonna, it's 90%, right? So you need to assess the airway.
Mm-hmm.
Let's say you assess the airway and it's a difficult airway. So how do we know that the patient is difficult airway? So show me how we're gonna assess the airway.
So I'd look in, I would see like the Malapati.
Yeah, so if he can open his mouth and stick out his tongue, you can look to see.
And then, we wouldn't know if the patient had like history of like prior difficult airways or intubations or things like that. Isn't there age a factor?
No,
Like,
not yet,
no?
not yet.
If I can see like into the back of the throat, but that's also with the tongue, but like if there's any airway swelling going on.
So let's flip your papers, and if I have one quickly, I can be. Give me an additional one. No, he has something. Yeah. So anyway, so if you flip your papers quickly, this is called the SAVE score. The SAVE score is invented in Brockton Hospital, by the way. So this is our own score, but it has all of the components of the score are actually components that has been studied and established. They just put them together, right? Because nobody knows really when they tell you that Madame Patty's score is 2, which is good. Maybe the guy has a neck like this and he can't move his neck and he can't open his mouth. It's still a difficult airway, but Madame Patty's score is 2. So they don't work in isolation. They have to be together. So Professor Emily, can you read for me the things that will give you a difficult airway and the score next to them?
Yep.
Quickly.
So having a difficult airway hit a score of 5, disease associated with a difficult airway score of 3, Malapati score, if it's a 3 or 4, it's a score of 2. HMD is a score of 2. If it's less than 2 finger breaths.
Right.
Breath.
But somebody else needs to. Can you come in and do those for us?
If their mouth
Let's just say
opening
no.
is less than 2 finger breaths, then 2. Neck mobility, if it's less than 40 degrees hyperextension, it's a score of 2. Neck circumference greater than 40 centimeters, a score of 1. BMI, if it's over 30, it's a score of 1. If over 40, a score of 2. Thyrosternal distance, if less than 2 finger breaths, then a score of 1. Mandibular angle, if it's obtuse, it's a score of 1. Upper mandibular protrusion, if it's present, it's a score of 1. Absence of upper incisors, -2.
So what's your score, Amina?
For this patient?
Yeah.
So patient, I have no idea of his history.
So he doesn't have a difficult airway. He has angioedema now.
Angioedema.
His
So
tongue
he
is
has
protruding.
disease. It's 3.
Yeah.
His Malapati score is low, so I'm not going to give him any points for that.
Yeah.
His HMD is less than my 2
Yeah,
finger breaths.
it's
Maybe
less.
not yours, but 0 for that. Mouth opening, I would say is.
So no, so the HMD is less than 2 finger breaths, which means.
It's
Is
greater.
it more? No, it's greater. Okay.
It's greater.
All right.
For the mouth opening, I would say that it's less than 2 finger breaths. Just I don't have a lot of mobility here, so I'm gonna give him 2. So that's
Okay.
5 right so far.
Yeah.
For hyperextension, I really have no mobility
He's not
here.
moving at all.
So I'm gonna give him 2.
That's
That's
7.
7. Neck circumference, 40 centimeters. I'm gonna say that it's
So
not.
this is only, everybody should remember his collar size, right? For men, we know the collar size, Mine is 48. So this one is smaller than me.
Yes.
It's probably easier.
I can get my fingers around it.
Yeah.
So I'm gonna say nothing for that. His BMI, he doesn't have a body, so I'm gonna give him nothing.
Mhm.
Thyrosternal distance is definitely, it's greater than 2, so I'm not gonna give him any points for that. His mandibular angle, I would not say that it's obtuse,
Mhm.
so I give him 0 mandibular protrusion is absent, and he has all his teeth, so I have 7.
7. 5 or more means difficult. So typically, when we do the score like this, if you reach, I let you go through the whole score, but if you reach to 5,
You
from
just
number
do
1
it.
or 2, you just
Okay.
stop. And that means difficult airway. So now we're gonna ask somebody, please bring the difficult airway card. This doesn't work anymore. We have to get the difficult airway card, which they got it for us. The nurses should know by heart what's in every one of those. If you're sitting there, you know, I'm not saying doing nothing, but just open this and just keep looking at it throughout your calls, your shifts, or whatever. So let's say now it's Professor Gonzalez. Come on in. So we have right now we have somebody who's a. Thank you, Emily. So we have somebody with a difficult airway. Come on in. Come on in.
It's you.
It's you.
So we have somebody with a difficult airway assessment. He's a difficult airway, saturating 90%. He vomited once before, and his mental status is horrible. And they brought the difficult airway card for you. What's the first thing we do? What is the nurses? Come on in. Where's it, California? Go for it. So what are we gonna do? You're both in the room now. This is the situation.
Yeah, so we were
What's the first thing that needs to be done? Simple.
Head down.
Head down, and something else with the bed. Pull the bed away from the wall. Pull it south. You can't imagine. No, the head only.
And the head down.
The head down. And pull the bed away from the wall because you can't imagine the frustration of somebody coming in and you can't get behind the bed. Happens in every code. Every code I see, I go to. All right. So yes, we'll move the bed down so somebody can stand behind the patient. Remove the top of the bed. Yeah.
Pull it up.
Okay, pull it up. Okay. Now put it somewhere.
I got it.
Okay. And now go behind the patient. Lock the bed.
Locked.
Right. And you stand behind the patient. And then what are we gonna do? Remember the.
Or we can start getting the stuff prepared.
Getting the stuff. So.
And I can
So,
ventilate in the process.
can I just summarize the stuff in one word? Miss Madman. Miss Madman. Remember me, I'm the madman, and he was the miss. So Miss Madman, right? So Miss Madman is M is for machine, so the respirator is bringing the machine. S is for suction. The other M is for method. So you have to have another method available. If we're gonna do with a glidoscope, we have to have a bougie. If we're going with a the regular laryngoscope, we're gonna have a glidoscope and as a one backup method at least available in the room, right? And then the A is for airway, so we have to have oral airways, right? We're gonna find all of these things. So can somebody else, when I say things, just find it quickly because we need to find this stuff. So just going back a little bit, when you get this box, even if it's not a difficult airway and you're just gonna use this box, there's only 3 things we need from it. 3 things only: the endotracheal tube, the CO2 detector, and the endotracheal tube, CO2 detector, and the syringe. That's it. And the rest is glidoscope. Usually when we intubate, right? If you're gonna use the regular scope, the Mac or Miller blade, then they're right here on the top. But typically that's what you need. And that's to get you started, and other things that are available in the room. But also you have here a suction catheter and a nasal cannula. You really. By the way, also the last mock airway we've done, we didn't find a nasal cannula in the room. People were just running all over the place. This has a nasal cannula and this has a nasal cannula. If you bring the card, the whole card has a nasal cannula in it, so you can quickly jump into things. So we move the things. So we talked about Miss Madman. M is machine, S is for suction, M is for method, A is for airway. You found the oral airways, right? And the nasal airways. D is for drugs, right? So she asked for the drugs. What are the drugs we're gonna get? Just remember, very easy, very easy. So something to put him to sleep, something to paralyze him, something to treat the blood pressure, and something to sedate him after, and fluid, right? So whatever, his blood pressure is okay. So propofol sucks, and huh?
Hydro?
Well, we were talking about low blood pressure probably when you get intubated to use the drug. So we're gonna do Neostick, a little bit of fluid, and Versed. So these are the 5 things that quickly we can just when we do this together many times, you're just gonna know what to get and get them right. not gonna go wrong if you grab etomidate, by the way. Etomidate is better than propofol in a way that doesn't drop the blood pressure. We don't usually ask for it, but if you grab etomidate in preparation for something, or if somebody doesn't know, you know, we have a new PA coming, for example, maybe he doesn't know what to order, right? So here's the stuff that we use. Etomidate doesn't drop the blood pressure, so etomidate and Sux, you're never gonna go wrong with it. Okay, I have to spend 1 minute every time I say the word Sux to remind people that Sux is a dangerous drug. It can cause what? Why is it dangerous? So it can cause malignant hepatitis, but I've never seen one, so it's very rare, extremely rare. But what's more common in Sux that actually kills people on the spot?
Malignant hypertension?
No, that's malignant hyperthermia. We said that, but it's very rare. The one that kills people is hyperkalemic cardiac arrest. So it does raise the potassium. In normal people, it raises the potassium for about 0.5 milliequivalent, which is nothing. But if somebody has renal failure, somebody has Duchenne muscle dystrophy, or Becker's muscle dystrophy, or bedridden, or paralyzed, or have burn more than 30% body surface, area burn, all of those people can actually develop a very, very high, like go from 4 to 8, for example. There's one particular class of patients that I really worry when we do this about, which is acidotic patients. Because acidotic patients, the hydrogen and potassium exchange across the membrane instantly. So your potassium could be 4 today, and then we give you 2 milligrams of dilaudid, you stop breathing, your potassium is 6 already, without measuring, because the hydrogen and potassium exchange. So if I give Sux on top of this, so be careful. If this patient just hypoxic, yeah, we can use Sux. If he is apneic, then he's acidotic. Then you don't use Sux. Use other muscle relaxants. Okay. This is just a word I have to say about drugs, which is not our.
Also renal.
Yeah, we said renal. Come in the door, madam, so you can listen to everything.
What's the alternative that you use?
We can use rocuronium. Yes, you're right. Renal, and we did mention that. Renal failure, they can't handle Sux. Rocuronium is the one to use, and rocuronium, unfortunately, it paralyzes exactly like Sux, but the paralysis lasts for 2 hours. So you have to have something called the reversal, which is sugammadex, a medication called sugammadex reverse. Professor knows here.
Professor.
I love it.
How are you?
Okay, so the
I
rest
want
of
to do the crank though.
You're here for the crank?
Yes, I want to do it.
15 minutes. All right. So anyway, so the D for drugs. The other M is for what? Method, machine, and what? Monitor. You know, the pulse oximeter is working. You know, all of these things, right? And then the other A is for we said one airway, and the other one is.
You don't know, I don't know.
Yeah, it's just blanking. The other N is for nasal cannula. So the last N is for nasal cannula, and the nasal cannula don't remove it during the actual placement. So I think critical care medicine say you have to give oxygen continuously throughout the whole process of difficult airway management. Okay. So we got the Miss Madman. What else? What's next? We got the drugs. We got Miss Madman.
Yeah.
Position the patient.
Yeah, position the patient.
Yeah. What's the position that you want the patient in?
You can have him like in the sniffing position.
Yes, the
And
sniffing
so
position.
take off the pillow,
Yeah.
put him flat, raise the head up and the chin up.
Yeah, and ideally you should put something under his shoulder, like a little folded towel or something under his shoulder that gives him a little bit of a sniffing position that makes it easy for you. Okay, now he's breathing at 35, saturation is 90%. Call the family? No, there's no calling of the family. That's why these people have DNI and DNR and full code and all of these things. That's why we asked this in the beginning, right? If you don't know, that's a different story. But you ask if the patient is full code. Yes, full code. Then we're gonna intubate the patient. There's no time to. If you call the family, you could be blamed for it because what are you doing? You know, the patient is anyway. And this was okay. So we assist the airway. We did the safe score. What else are you gonna do? What's the next step? Everything is available now for you.
It's determining what mode I want to use in.
Yeah. So he's a difficult airway.
Yeah.
He's a difficult airway. He has some oxygenation. He's not dying right now. He's 90%. He's breathing at 35. His mental status is not good.
Yeah. I mean, I could do like an intubated LMA if I want to.
That's jumping so much.
So I mean,
Think realistically. What would we do in this ICU?
the glide scope.
Glide scope. The glide scope is the way to go. Don't start with this because if you start with the Mack and Miller blade, they will actually they're not gonna be, they're not designed for difficult airway, right?
Yeah.
Right, try to do this. Try to see if you see anything.
Yeah.
So, okay.
Yeah.
All right, so assume that you couldn't see it, then it becomes the gyroscope now, right? So what is the gyroscope? Can we bring the gyroscope, please? Please. Meanwhile, as you're getting the gyroscope in, what are you holding in your hand to do?
Ambu bag.
Ambu bag. So please, the ambu bag. And as you're doing the ambu bag, before you put it on the face of the patient, you're trying to assess what?
If they're breathing, if they're.
Well, no, we assessed all of this. So there's four bridges. The intubation bridge, the oxygen, the ventilation bridge, the cripe bridge, and the cooperation. So is he an easy cripe? Yes, he's an easy cripe. Is he a difficult intubation? Yes, he's a difficult intubation. Is he cooperative? He's cooperative, right? You know, I can tell him things and he'll agree with me, right? The last bridge that we need to assess is the ventilation. Is he ventilatable by mask? Because if we burn two bridges, that's a very difficult situation, and you have to go to awake fiber optic intubation. So before you put this on, there's no good score in the literature about ventilation. By the way, you really don't know if you can ventilate somebody. But I have my own score. You know what the score is? It's called Santa Claus score. If the patient looks like Santa Claus, he's a difficult ventilation, right? If he has, you know, huge beard, no teeth, big nose, and 400 pounds. That is a difficult ventilation. And any modification of this, then that's a degree of difficulty, right? So he looks like this. So he looks like he's easy in ventilation. So we're gonna put the thing on him. And now his saturation is actually going down. You can, so you can you ventilate? Yes. We assess all the bridges, right? And you look like you can ventilate, so this way we're gonna say gyroscope, right? Now, Trish, can you come here, please? That's the next scenario, okay? And we'll rotate around. Amanda, wanna exchange a little bit?
She's taking my place.
Yeah. Yes. So now there's a different scenario now. So this patient is already, we intubated him already, right? Let's repeat again. Maintaining oxygenation, he's at easy ventilation, he's a cooperative, he has easy cripe. The only bridge that was burned was intubation. So we decided to, because we can fall back on this, so we try to ventilate, and if we can't ventilate, then we'll do the gyroscope. Okay, now there's a different scenario here. He's actually difficult to ventilate. He looks like Santa Claus, right? So we can't ventilate him. So we can't ventilate and let me come from the other side. And I'll show you something here. So let's say, well, I can't come from the other side. All right, let's do it from here. Okay. So I'm ventilating him now, right? One second, let me ventilate. And Amanda, you come next to me. Right, so.
Cal, we have to go. I'm sorry.
All right.
Thank you.
Thank you for coming. All right, so anyway, here. I'm trying to ventilate. Am I ventilating correctly? All right. How do I ventilate correctly? Yeah, but where do you put your fingers? So from here. So let's Trish, put your finger, Trish.
Yeah.
Where do you put the little finger? Little finger under the mandible. These two fingers here. Pull up.
Okay.
Right, Professor Bertucci?
Yep. You're not touching the soft tissue underneath. You want to put it on the mandible. Okay.
Oh, well, I didn't know, you took it from me.
Right, you're moving along.
And
Beautiful,
then
right?
half a squeeze.
So let's say I'm doing this. Hold on. Right, I'm trying my best. What are you gonna do, Amina?
I'm gonna correct your position.
Yeah,
Still have somebody else.
so you're gonna come here,
Yeah.
right? And I'm gonna
Two of his.
hold with two hands. They call it the two-person technique. So now I can improve my seal, and you ventilate. Don't do like the orthopedic resident who ventilated once and left. Squeezed it once. Anyway, so right here. So we did like this, right?
Yeah.
There's
You
still no,
still don't have a
there's no
seal.
seal. So what are you gonna do? Yes. And Amanda, I still have a seal. What are you gonna do? Yes.
Somewhere else.
Yes, you find where the seal is, right? You put your finger there so you can see the air coming out, and then you put your finger. How many people can hold this? 8, 9, 100. as long as we can give a seal, we're gonna get very close to each other. As long as we can give a seal and give 2 breaths, we are golden for another 5 minutes, right? Good 2 breaths with 100% oxygen will give us a good amount of time later. So this point here, it sounds like it's not really very important, but I forgot this when I was young 1,000,000 times. That's something that you get by experience. That you have to stop looking at the toys. You have to actually, this will make you actually look fool. Because when you get the oxygen inside the patient, then you have time to work, right?
Yeah.
If there's no oxygen, everybody's rushing you. Okay, so you're ventilating this. Amanda, help her, please. So now we're ventilating the patient, right? And now we got the saturation barely to 92%. So the saturation is 92%, and he is difficult ventilation. We found out that he's a difficult ventilation.
But we can ventilate now.
Well,
Does this count as can't ventilate, or no?
this one counts. So this one, if it's difficult ventilation like this, and you get it with multiple people, then you use a glidoscope.
Okay.
We'll go back to the glidoscope. But let's say we couldn't. 8 people holding the patient, and we couldn't ventilate the patient. We still can't. So what are we gonna do?
Intubating element?
Nope, not yet.
What are we
So
getting?
think about it. We have 2 bridges that are burned now: the intubation bridge and the mask bridge. The ventilation bridge. We have 2 bridges. So are you gonna put this patient to sleep and depend on the crike? Like that'll be your fallback position. The crike. That is a horrible. Nobody, by the way, gets sued for airway because of a technique. You get sued for a decision. So what I always say, don't take somebody's breath away if you can't give it back to them. If I take your breath away by medication, I'm responsible now for it. If you're breathing on your own and I do whatever and you still die, I'm sorry, I tried my best. But I didn't take your breathing away. Okay? Dan, right?
Yes.
Yeah, so you're gonna be next. So come close, Professor. So what are you gonna do? We said we're not gonna do glide, right? Because it's difficult ventilation. We're not gonna put him to sleep at all. So what are we gonna do? Awake fiber optic intubation, right? We have the fiber optic here, right? Yeah. Let's get that. And then please connect it. Not here, not here. The other one.
This
I was
one?
unconnecting that one though.
How do we get it out? Oh, there we go.
Right to the top.
Top.
Yep.
Thank you.
Maybe USB port. Yeah.
People love it.
Doesn't say it might be the other one. There
Yep.
you go.
Okay. So now we have the fiber optic. Okay. Now what's next? So you can leave the ambu bag now, right? Although this is a good training, by the way. They used to leave us for hours doing this. Anesthesia, isn't it?
So you want me to put
Yeah.
it here?
So what we're gonna do is basically, hold on. Leave the fiber optic for a second, because nobody's gonna tolerate the fiber optic just by doing like this. What we're saying here is that we can't ventilate the patient, but his oxygenation is fine. It's 92%, right? 92%, but there's no way we're gonna ventilate this guy. So we decided that we burn 2 bridges. We're gonna go to awake fiber optic intubation. So we're not gonna give him anything other than numbing his airway, right? Or maybe at the end we'll give him something just before. But we have to start numbing the airway, and we have to take our time. So awake fiber optic intubation is a safe procedure. You're probably not gonna lose anybody doing it. It's gonna take time, and it's supposed to take time, right? If it doesn't take time, if you actually cut corners, you are not gonna be able to. You're gonna spend so much time in the airway. So how are we gonna numb the airway? Everything that is needed for numbing is in the first drawer here. Open the first drawer and give us all the meds there. It's in one box. Yeah, there's the whole box here. There's so many. All right, so right here. Do you open the box? Do you open the box? Show me. Things take time. Tick tock, tick tock, tick tock, tick tock. See, patient is dying.
You need to rip it.
Let's rip it.
Just break it off,
That's
twist it.
Twist it from underneath here. See? Aha.
Very
This-
aggressive.
This small stuff. All right, so this is your thing. The first thing to start with. Do you have the app?
Yeah.
Yeah, open the app, please. First thing to start with. So I always say this takes about 20 minutes. maybe 15 or something. I can do it quicker if the anesthesiologist is there and they can do a block. So I can do a quick block. I can do a block here. I just hold here the hyoid bone, push it from one side, inject in this side, hit the hyoid bone on the other side of the hyoid, and inject here. I numb the superior laryngeal and do the same from the other side. This is bloody, horrible. It takes, it just takes 2 minutes, but it just, and it doesn't work half the time. You got it? So right now she has in her app, and you guys are welcome to get the app too, by the way. So in 20 minutes, what are we gonna do?
Reglan 10, Robenal 0.4, ETT in warm water.
Okay, so that's in 20 minutes. We put the ET tube in warm water. So first nuke some water there and just put it in the, and then the Reglan to move things down so it doesn't, and the Robenals to dry the secretion. Next 10 minutes.
4% Litoneb, Catechane spray.
Cytokine spray.
Cytokine.
So wait, so 4%, we're gonna ask respiratory to come and give us a the big neb and put this in it. That's the 4%. Cytokine spray, this one here. Right? And where do you gonna spray? You start with the tip of the tongue, then you go, as you go, and then the most important ones are the 2 tonsillar pillars on both sides. Okay, so that's
I have the straw in it.
and it has a straw attached to it. Right? What's next?
Atomizer, Lido?
So this is the same one, 4%. We put it in atomizer. Can you bring the atomizer, Professor? This is like an old woman's perfume thing. Put the atomizer together, please. Alright. And next.
Viscous lidocaine?
So the atomizer can actually go all the way to the back and actually numb the larynx itself, or above the larynx. And this is viscous lidocaine, right? And I use that at the end, right? Because sometimes they can't swallow it themselves. So it could be an emergency when you give this. Be careful when you give this. If the patient is like running at sometimes they choke on this and then they go. So last thing before I intubate, I give him, just take this viscous lidocaine, keep it in your mouth as much as you can, gurgle it, and then swallow it, right? This one here, it goes, like this, right? But then if you remove this, you can actually turn this down like this, see? And I can go all the way back and push at the larynx. Like I actually spray at the larynx. So that's, and epiglottis and stuff like this. All right, so we put those here. And then what's next?
Lidocaine ointment.
Lidocaine ointment. Right? So the lidocaine ointment is to numb what? Not for the patient. This is ointment, so it actually sticks. So it numbs the airway itself, like the actual airway. So if you open the second drawer, third drawer, I don't know where they are. This one here on the left side. See this orange and yeah. This is called what? This is called the Williams airway. This is the best airway. There's 2 sizes, large and small. Right? This is small. So you're gonna measure it, right? Against here. So yeah, this one goes to the zygoma, and this has to pass here, past the angle of the mandible. So this is too small for this guy. So let's say we got the large and we put it. So you put it exactly in the middle of the mouth. But before we put it, we put this paste all the way here. So even though if there's anything missing from the numbing, this will actually sit on the tongue and will be it doesn't feel. So let's put it in the middle. Right? So now, we're almost getting ready. We put all the numbing. What else is left there?
You have Afrin nasal spray and Neo Lido soaked Q-tips.
Okay, so these are not really 100% necessary, but it's done in case we're gonna do a nasal intubation. So this guy with a big tongue going out like this, we're gonna do a nasal intubation. So what we do is that we use a lot of Afrin, not 10 something, and then we do a solution of what? We get Neo, a small vial of Neo, which is 10 milligram, and the rest is 9 cc's of 2% lidocaine. Put them both together, mix them, and then get Q-tips and start putting the Q-tips very, very, very slowly in the nose, right? And then after the Q-tips, what do?
At 1 minute, Haldol and Benadryl.
No. So that's not written there. So serial dilation of. Can I have a nasal airways there? Do you have nasal airways?
Oh, there was one here.
Yeah, these are the bunch of nasal airways. So basically, it starts from 28 going all the way to 36 in adult males. So I think that after I put the the Q-tips for some time, then we go nasal airway and then remove it. And then another bigger nasal airway and then remove it until we reach the 7-6. The reason we're doing all of this because the tube itself as it goes, whether it's 7-6 tube, is still much bigger than those airways and will just knock all of this mucosa and cause problems. All right, so we're done with all of these things. So let's go. Yeah, let's see if you can do that, and then we'll have Professor Gonzalez do it and Professor Trish do it. What are we gonna do? What are we missing here? There's two things missing. He's too eager to do the scope. I gave it to him.
You need an ET too.
All right. So we need the ET tube. So the ET tube will choose a small one, right? Because we'll whatever. Let's say we have this on. This is a big one because I don't have a lot of. This is lubricant. This actually works as a lubricant. Right?
I was like, what?
We put it through and look here. Look here. There's something to hold it here, right? There's something- Right? So it stays up. It was one of those stupid things that the anesthesiologist said. All right, what else is left to do before you start? Before we start, we have to put the bed all the way down because your scope has to be straight, not taut, right? And then what else? What are we gonna use here? So suction, if we're doing a bronch, but if we're doing intubation, you need oxygen. So let's get the oxygen tubing, which is a thick second drawer, and it's an oxygen tubing that has two ends exactly the same. No, I think fourth drawer then. Changing on me.
It's fast.
Yeah, right there. No, this is a mess. Oh,
Oh, yeah,
no. Right here.
Okay.
This is needle cannon. Yeah, this one. Two ends exactly the
Alright,
same.
we'll figure it out.
Right? And this actually by itself, it does a lot of good things for you because what it ends up doing, let's connect this here. Huh? What it ends up doing is that it insufflates at 6 liters per minute. And that's what it does is that it pushes the secretions away. It actually stents the airway open and give oxygen to the patient. Like you can't ask for better than this. So every time you're gonna press this button, oxygen is gonna go inside the patient. And we turn it like this, hold it with the left hand. He's never done one before, so. All right, let's see if he can do it without doing one before. Keep the thought, right? Keep going. So let's say you've here.
Go back.
Go back. So that's the esophagus. And that's the larynx right there. Turn it. Right. Bring it to the middle of the screen. Right. And then is it in the middle? Yes. So if you push, it's gonna go in. And you need to adjust that position. Oh, it's not in the middle anymore. So what do? Retroflex. Push by this one here. Push this up. Yeah, and push. Oh, turn. Push it up again. Up. Yeah. Push. You're in. You see the trachea rings? That means you're in. Trish, let's do it.
There you go, that part.
And
What
I
am
mean,
I doing?
you wanna do it?
Do what?
No.
I'm gonna,
But it's really interesting.
Why not?
so do you want, just take
Do
it
you want
out
me to
and
take
do
it
it
out?
again?
Just
Is
take
that
it out
what
all the
you're
way to the nose. Don't take it all the way out.
saying? Don't take it all the way out.
Yeah. Or take it all the way out. I don't know.
I don't know.
Good
Yeah.
job, first time,
All right.
on the spot.
All
All right, here, let's go. Retro.
Just what you should do on a road trip.
Yeah, turn it a little bit. It's not in the middle of the screen. Yeah, bring it to the middle. Push. Yeah, you have to take your time when you do this. If you are rushing, if this is not exactly in the middle of the screen and you push, it's gonna go in the wall and make the patient cough. You have to be exactly in the middle. So, Amina.
It does smell like a cough drop. It's a hurricane spray.
Yeah.
Honestly,
kinda
this
nice.
is really cool.
All right, so where are you? Come out. So when you don't know where you are, you come out. No? no, see, the scope has to be top like this. Alright, so we'll go. Oh, we're way up, so we're gonna go through it, flex,
They did recommend.
flex by bringing this down. Oh, you found it, yeah, right. Right, and then retroflex. What is this, he has a tumor? Alright, now flex, perfect. No, retroflex now, retroflex, no, the other way. Yeah, push, yeah, you're right. Alright, Gonzalez. Yeah. You still have 10 minutes. You still have some other two other scenarios.
I just removed myself from the camera.
Yeah. Yes. Perfect. Turn. Perfect. Center it. Yeah. Perfect. Retroflex. No, turn. Yeah. Perfect. Good. And who's left there? Professor Drake. Nancy, I'm gonna have you intubate. This is gonna be the first physical therapist that intubate. Come on.
Probably about 30 years ago, we had a patient with a like C2 fracture down in the rehab gym, and she coded on us, and somebody handed me an airway, and I'm like, yeah, no. Thank you.
Perfect. I think he has a tumor.
Yeah, yes.
You're upside down, madam. You can intubate upside down. It's not completely. Right, Nancy.
Oh, are you kidding me?
Yes, I'm not
Here, I'll
kidding.
leave it in the nose.
I'm terrified of
Well,
this.
you're here.
Well, I'm not gonna kill this guy, so.
Well,
I'm on this
just
one.
go, just.
Okay.
If it's time to.
So.
Use your dominant hand as
Just
opposed to-
change
Yeah.
places.
Okie dokie. There we go. All right.
All right, so your airway is here, okay?
Mhm.
Yeah, hold it here with the right hand. Change hands. This is the right and this is the
Okay.
left.
He's gonna do something.
Right?
Yeah.
And
Like this.
no, let's
Like
push.
you.
Flex, so bring it down. Oh, too much.
Yeah, see.
Push. Turn. Push. Push it with this hand, yeah. Keep pushing. See, it's right there. So what we're gonna do, we're gonna retroflex, the opposite of this move. So bring this lever up like this, so we can avoid this booger there. I don't know.
Yeah.
More. Push it up with this finger. Up. Yeah, and then push. And then it will close. So now we gotta push it down. Push that lever up.
Yeah.
Yeah, perfect. And then push it up. Yeah, so push up and push. You're in.
Woohoo!
She intubated!
Hey!
First medical therapist. Okay,
Yay!
come on in, Gonzalez.
There we go.
Professor Gonzalez.
Thank you.
All right, good job. So, okay, so we're done with this scenario. That's the fiber optic intubation, right?
Yes.
We forgot to say call the team, by the way. You have to call the team. As soon as the thing is in, propofol is hanging, right? So that's, for all of the medications that we give, we forget always that the propofol has to be hanging on the patient's IV once the thing is in the tube. Then you wheel the tube over. If the tube gets hung on something, what do? You turn it. You turn it 90 degrees until it passes, right? Once it passes, then the nurse will inject the propofol, okay? Right, now, next, as you're preparing.
Question, is there a smaller ET tube or is that?
No, they're smaller. Yeah, this
There's a
is 8.
smaller,
We usually
okay.
small,
I
but
was gonna say,
just-
that's not gonna go in
it wasn't.
his nose.
I didn't have good lubrication. So anyway, preparing for the fiber optic scope. As you're preparing, the patient vomited now. He has small bowel obstruction, right? And his saturation is 90%. And so what are you gonna do?
Hook suction up to the, are we still using that scope or not? We have a different scope.
No, we were just preparing. So we can
Is that
do the
gonna
NG
do
tube.
things?
So let me tell you. So his saturation now is 85%.
Suction on as much as we can from the lower pharynx and then try to intubate.
So he is, as we know, that he's a difficult intubation. We know that he's a difficult intubation. That's why we were preparing the fiber optic intubation. So that's going to be a struggle.
Okay, so his oral airway is compromised, is this something to do with
Correct.
surgical airway?
Exactly.
Surgical airway.
There's no way. Why
Is
are you
that when
saying
you crack them?
Yes, that's when you crack them. You should say that in a loud voice, madam.
Sorry, I wasn't sure if I said.
Anyway, so you're gonna crack the patient because if you think about it, that's not too aggressive, by the way. There's vomiting in the airway. That's a disaster waiting to happen. The saturation is 85%. You know he's difficult intubation and difficult ventilation. What are you trying to do here? You're gonna try to do intubation for like take 10 minutes to intubate them? You're not gonna. So crike. So let's get the needle crike. It's in the bottom drawer. It's a little cylinder.
Is it still in there? Oh, it's still
Yeah.
there.
So Professor
I think
Amina,
it's center.
take this. All right. So.
Worked out. 1, heart rate 132.
All right. So.
Open it.
Yeah. Can we get a box, you know, any box of anything, or something to puncture, just to get the feel. Here, you do this. I got it. All right, so here. So the first thing you do is this. I'm gonna use this because you can't puncture here. So you come here, come close to us here. Stay here next to our professor. Right? So how do you find the cricothyroid membrane?
So it would be like right below where I would think the thyroid is.
Yep.
But I can't really feel any landmarks on this.
So you're not gonna see landmarks. So
No.
you put your 2 fingers like this exactly on it,
Okay.
like this, and then deep palpation, and you go down until you feel like you fell off the cliff.
Okay, and that's your cricothyroid.
That's it.
So like right here.
That's your cricothyroid membrane, and then immediately after this you do what? Let me see.
So it's at the point where you've fallen off the cliff.
Yeah, you fall off the cliff. That's the cricothyroid. Underneath is the cricoid, and above it is the thyroid. And then you do what? You spread.
Okay.
Look at the dimple here.
Yeah.
You know, I dimpled the skin. The reason I'm dimpling the skin is that we're not supposed to. The skin has to be very close to the cricothyroid membrane, because if it's not, you can fit the trach in between, and that's called false trach, and that's what everybody's scared of. By the way, I'm saying it on video. I'm gonna put it on YouTube. Do not listen to the New England Journal of Medicine video that they have. It is horrible. They cut like this, so they can see the cricothyroid membrane. That's not okay, because that wastes time, and that's great for cadavers. But if for a human being in a situation where you don't have surgeons, for example, and you don't have cautery, and you don't have light, and you don't have nothing, so you just open like this, fountain of blood comes out. What are you gonna do? You guys freak out, and half the nurses are gonna run away, right? So we're gonna cut like this, so then we can feel it, and then we can cut, and then we cut horizontal, and then put something called. Can I have the cric kit, please? It's on top, the top.
This one?
All the way. No, yeah, this one.
That one. Hey.
Right? So there's something in the cric kit. It's called, the tracheal ring crusher. And I'm not joking. It's called the tracheal ring crusher. It actually crushes the tracheal rings. So very medieval way of doing this, and it's really suitable for the OR. If you really want to do it. So this is the tracheal ring crusher. So after you cut vertical and then horizontal, you just go like this and put this one inside, and when you push like this, it crushes the thyroid and the cricoid and everything, makes a big like blast hole inside like this. And then use this thing called tracheal hook, and literally you are trying to bring the laryngeal mucosa close to the skin. So what you do is just literally, randomly and blindly, you go inside and fish for something until it hooks on something. Could be the vocal cords, who knows? You just hook up on something, and then you put the tracheal tube, the cric, this way. It doesn't work. This is horrible. So what I would do, I would just do like this. Put your finger there, spread them. Don't leave this anymore. This is like a death grip now. This serves 3 functions. Number 1 is protecting the venous plexuses that are here, so you don't cut them. And number 2, making the two close to each other, so when you cut with one move of the scalpel, half the scalpel in, you'll be cutting both skin and membrane together. And number 3, you'll never have a false passage, because they're so close to each other, and the tube is so big, it's not gonna go in between. So the key here is death grip, dimple, cut in between your fingers, and quickly put it in the tracheal tube. That is the open cric situation. For needle cric, what are we gonna do? We're gonna prepare stuff. So where is the needle?
It was here. There's
right there. So first we'll put some water into this. Right? And you do the same thing with the left hand, and you come from above. Of course, we're not gonna puncture this guy because it's not supposed to be punctured. And then you're gonna go 60 degrees angle like this, as you're aspirating.
Like this.
Yeah, as you're aspirating, right? So you put your finger, wait.
Am
like
I
this.
pulling out?
You have to do it like this. So with this finger you can aspirate. This is the needle crike, right? Yeah. Perfect. Yeah, just like that. And as you go in, you go in slowly. Once you see bubbles in here, that means you're in. So let's puncture this and assume that this is the patient because, right? So we puncture this here, right? We know that we're in, right? What's next? This one here.
Okay.
This comes as, see, a wire and a dilator at the same time. It goes inside the endotracheal, the crike, like this. Wait.
Oh, sorry.
And we're gonna put it through. But it's gonna stop, right? So what are we gonna do? We're gonna break it like you've done. You're gonna break these two apart.
Apart.
Yeah, remove them completely.
Oh, okay.
Remove the two sides.
Got it.
Break them and remove. No. You break and remove. No. Break them. Pull them apart.
Like separate them.
Separate them. Yeah,
Oh,
exactly.
okay.
And that remains inside like this.
Okay.
Right? And then you have a scalpel here. You make a cut and advance the whole thing. Right? So we cut here. Yeah, just like that, yeah. As if you're doing a central line. Yeah, deep, more. Good. And now advance this. Yeah. It's gonna feel like this. It's gonna feel difficult. So you're gonna have to really put your finger on this, on the obturator, and push hard. Yes. Keep going. Yes, that's it. And then you remove the obturator and you're done.
Okay.
All right. So we're running out of time. So I quickly tell you about the last scenario. You can ignore the needle crike and just go for open crike if you know how to. I'll go open crike right away. This takes 1.5 minutes. Open crike takes half a minute. Right. And then of course the scenario where we're having can't intubate, can't ventilate, but the patient is not vomiting or doing anything. There's upper airway, just can't ventilate, can't intubate. So what are we gonna do? We're gonna have to start with the intubating LMA, the one that you mentioned. Can I have it from behind you? No, that's LMA. This is LMA only. I removed it from the difficult airway.
Where?
No,
No, it's okay.
lowest drawer. So intubating LMA is a lifesaver. Lifesaver.
This one?
Yeah. All right, so I'll get it out for you quickly because we are at 12 o'clock. So right here, that's a component that we don't use acutely, and this one is what we use acutely, and it's missing an endotracheal tube. The first one was an endotracheal tube. Oh, right here. Okay, so remove this. All right, we're supposed to test the balloon. Remove this, and put 20 cc's. This is how it looks. Right? Pull it back. Okay, now I'm gonna lubricate it with this. It's not the best lubricant, but I'm gonna lubricate with this. What you do with this, you know how the regular LMA, can I have the regular LMA? Yeah. Or actually, there's LMA open here somewhere. Yeah, right there. The regular LMA, just anyone. Here, you go like this. Put your finger under the bell like this, the nails, and you go here, and you try to, this is not in the difficult airway algorithm, by the way. I'm just telling, it's showing him because he's an anesthesiologist. I don't like it in the difficult airway algorithm. This is better, right? So he puts it, and the fingers are there to push against the hard palate. You're literally using these two fingers to push against the hard palate as you're putting it inside, so it goes above the tongue, it doesn't push the tongue, right? But if you are not able to do, so this is what, I did this thing in Harvard Medical School. I told the kids over there, they were, what's going on? They don't, but anyway, I told them, if you don't know how to do this, you can just take this and shove it. like literally shove it like this. If you shove it halfway, it's gonna work. If you shove it upside down, it's gonna work. If you shove it sideways, it's gonna work. It is the best thing that was invented. It was invented by somebody called Dr. Brain. His name is Brain, actually. Anyway, so this one here, you don't put anything inside the patient mouth. You hold it like this, and you go with the curvature. Very easy, very easy, right? So that's LMA also, but that's why I like this better. And this one, yeah, perfect. And then we inflate this, and then through it we put this tube, right? We don't have time, but we're gonna put this tube. This device here is used by the anesthesiologist a day later to remove this. But acutely, if the nurse tells you, please remove this because it's in the way, just say, what are you gonna say? No. How about the combi tube? And this is the last thing we're gonna talk about.
I don't know where it is. Where
Yeah,
is
that's
it?
the one. That's the one.
This?
Yeah. All right. This is a combi tube, but we have one here. Can you see it in the yeah, right here. Perfect. This is the combi tube. This is foolproof. This is anesthesiologists hate this because it takes our job away. Right? Literally, it's made for paramedics to put it in somebody who's like upside down in a car wreck or something. Like this, intubated, right? So this just goes in anywhere. It doesn't matter where it goes. Most of the time, it goes in the esophagus, and then you that's it. You're done. You intubated the patient, and then here you put 12 cc's. Here you put 100 cc's. So that little balloon that you see in the pharynx is sealed the pharynx. And the other one sealed the esophagus, and these little holes here are going to be the one ventilating above the trachea. So this is above, this is esophagus, the trachea is here. So you test each one. You don't know which one is where. You put CO2 detector here. If it gives you CO2, ventilate from here. That's it. You know, so it's very simple. It's not a definitive airway, so it has to be changed. Then the intubating LMA is a definitive airway. You're done. You don't need to do anything else. This one has to be changed within 4 hours or so. But it saves the patient life. That's it, professors. Any questions, professors? With the emphasis on, what is he? Professor. He's a professor.
He doesn't know yet.
He doesn't know yet. All right, thank you very much.
That's awesome.
Thank
Thank you.
All right.
Can we end your video?
Yeah.